Hi there, my name is Tyler Dietz, and today I'm going to be talking to you about access and cost barriers to mental health. The study was conducted by insurance through the years 1999 through 2010. Some of the topics that will be covered in today's presentation include the summary of the health affairs article that I chose, some of the descriptions of the economic perspectives, some statistical analysis, and analytical methods used. I'm also going to go over the highlights and conclusions reached in relation to the coursework in economics of healthcare. The critical analysis will discuss some of the shortcomings in future research design suggestions. This article briefly discusses some of the issues faced by Americans in the working age group, ages 16 to 64 to be exact. There are many factors that determine if, when, and how someone gains access to mental health services. Although there will always be stigmas, attitudes towards treatment, interpretations of mental health symptoms, the cost is always going to be the largest barrier to access. Public insurance, private insurance, and the uninsured Americans with mental health issues face troubles accessing care daily, namely cost being the most reported barrier. Privately insured and uninsured Americans reported having the most issues with regard to cost restricting their access. The current financing for privately insured Americans results in inefficiencies under the Affordable Care Act, a topic that we will later discuss more in depth. Medicaid expansion will continue to shrink the privately insured market under the Patient Protection and Affordable Care Act. The demand for mental health care and hospital use will increase as many underinsured and uninsured Americans get coverage for their services. According to healthcare.gov, cost sharing is the share of costs covered by your insurance that you pay out of your own pocket. Cost sharing generally includes deductibles, co-insurance, and co-payments or similar charges, but it does not include premiums, balance billing amounts for non-network providers, or the cost of non-covered services. Oftentimes, however, mental health services are not covered. This is why healthcare policy changes will allow people to meet the income eligibility criteria and obtain premium subsidies in the form of tax credit. This will help pay for the coverage offered through an exchange, and subsidies will help cover their cost-sharing obligations. In this section of the presentation, I will briefly discuss some of the trends and statistics that the author of this article used to describe the differences in mental health access in America. The data for this study came from the Integrated Health Interview Series, which is an online database of more than 40 years' worth of data from the National Health Interview Study. This analysis was limited to the working age, ages 18 to 64, who were interviewed between 1999 and 2010. Each 2-year period was combined to give a more accurate response. Dependent variables include the use of specialty care and cost barriers to care. The use measurement was based on whether the respondent had seen a specialist in the last 12 months. The second measure had assessed whether the respondent believed that he or she needed mental health counseling or care, but did not receive any because he or she could not afford it. During this study, the researchers had broken the respondents from the survey into 3 mutually exclusive categories using a scoring mechanism that ranged from 0 to 24. Serious psychological disorders, referred to in the study as SPD, had a score of 13 out of 24. No mental health problems equated to a low SPD, and no limitations due to a mental health problem. Moderate mental health problems equated to either an SPD or a limitation. Serious mental illnesses equated to both SPD and a limitation. As you can see from this chart, in every 2-year period, the prevalence of mental health problems was significantly higher amongst the publicly insured than in any other insurance category. Medicaid, a state public insurance, is the single largest payer for mental health services in the United States. During the study period, the percentage of people with moderate mental illnesses who had public coverage increased by 34%, from 25.9 to 34.8. The percentage with private coverage fell by 21%, however, from 50.2 to 39.8. In each 2-year period, people with moderate mental health problems were more likely to be uninsured than people with no mental health problems. The rates of the uninsured did not change significantly from those with no mental health illnesses to those with more serious mental health illnesses, although these are the people who have a greater need for the services. People with more serious mental health illnesses were less likely than people within the other two groups to have private insurance and more likely to have public insurance. There were 43.5 to 47.5% of people with serious mental health illnesses that were covered by public insurance, the most common for this population. Among people with no mental health problems, there was an increase in the probability of accessing care for the privately and publicly insured. People with moderate mental health problems and private coverage, there was a 2.4% increase in the likelihood of using specialty care. For each 2-year period among people with mental health problems, the uninsured had the lowest access to specialty care. 20% or so with moderate problems and 44% of those with serious problems received care. On the contrary, the publicly insured had the greatest access to care. Approximately 49% of the people in the study with moderate impairments received care, while 69% of those with serious impairments received care. Across all three insurance types, the use of services increased with the severity of the mental health problem. The percentage with moderate mental health problems who reported that costs prevented them from getting needed mental health care increased over the time for all insurances. The lowest significance level was the publicly insured people. For people with serious mental illnesses, cost barriers increased for the uninsured and the privately insured. As one may presume, in each 2-year period, people with mental health problems, meaning moderate or serious illness levels, who were uninsured were more likely than the private or publicly insured to report these cost barriers to accessing their care. As evidence to support this assumption, 64% of the uninsured with serious mental health problems reported problems accessing care as a result of cost. In comparison, 18.2% of the public insurance and 30.6% with private insurance reported difficulties accessing care as a result of cost. You can see the stark differences in the cost barriers between those with public and private insurances and those without insurance altogether. The probability of cost barriers increased with the severity of mental health illnesses across each insurance type. This poses a problem of accessing medical care for the people that need it most. The decline in private coverage was greater among people with mental health problems than amongst those without such problems. Why is this, you may be wondering? Well, in part it has to do with workers taking jobs that are less likely to offer insurance, but there's also been a trend in reduction of employer-sponsored insurance programs to the middle and low-income workers. This means that it is important that there be coverage for people with mental illnesses. Looking back at the second chart that showed percentages of people by level of mental illnesses and insurance status, one can see that 47.3% of people classified as having a mental health condition were covered by a public insurance. This is in comparison to the 9.8% of people who are also covered by public insurance but do not have a mental health condition. How is any of this possible? Well, to simply put it, when it comes to mental health conditions, public insurance is more generous with their benefits than private insurers. Greater access to mental health specialists, and the difference in public and private insurance reflects the greater level of disability and the richer benefits of people with public insurance. Access to specialty care increased by the severity of mental health illnesses. This shows how important it is for the public health insurance programs. This seems great, however, when one takes a step back and re-examines the third chart, we can see that 33% with public insurance, 40% with private insurance, and 56% without insurance didn't receive the access that they needed. Why is this? It may seem obvious to some that there are such factors as stigmas or attitudes towards treatment and other interpretations of mental health symptoms that may be the reason for such low access, but cost is the largest indicator. Cost barriers for those with moderate mental illnesses who were privately insured or uninsured increased from 1999 to 2010. Cost barriers also increased for people with serious mental illnesses. Not only that, cost barriers were higher for people with the more serious mental illnesses. This reflects the need for a more frequent or intensive therapy for such mental health concerns. People who have higher out-of-pocket expenses will forego treatment, which leads to poor management of their illness. Remember, money is not being washed down the drain here. In terms of absolute dollars, out-of-pocket expenses are very high. Furthermore, they have the highest amongst those with serious mental health issues. One can clearly see the problem that this may cause. 18.2% of those with serious mental health problems that are publicly insured reported having a cost barrier, while 30.3% of the privately insured reported the same cost barrier. This is considerably higher than those with moderate illnesses. The Affordable Care Act has expanded parity provisions to new plans and specified that mental health and substance abuse services are an essential health benefit. However, self-insured plans are not included in the new mandate for mental health and substance abuse services. Certain small employers are exempt when purchasing coverage as well. Overall, the Act offerings are a great opportunity for those with mental health conditions. The author of the study put that if fully implemented, the Act could provide coverage for 3.7 million adults with severe mental illnesses. Medicaid expansions are optional by each state. States either decide to change with the mandate or choose not to. This limits the amount of people who may be eligible for insurance coverage. As of the summer of 2013, 24 states implemented this expansion. 21 states did not, however, and 5 states are still up in the air weighing out their options. The people left behind are those who are not eligible for Medicaid, which are the low-income adults without children. As the study shows, this is a group that have more serious mental health illnesses when compared to the general population. Taking this into consideration for future policymakers, we are now faced with additional challenges that need to be addressed. Access and cost barriers being the biggest. Rules, regulations, and implementation of the Act is now of most concern. In this section of the presentation, we're going to take a look at the economics of healthcare and see how all of this relates to our coursework. To summarize the demand side of the medical market, medical care demand is derived from the initial demands for medical treatments. The demand for manpower or its inputs is similarly derived from the demand for institutional care. When there are more people that are sick, more doctors are needed to be present. Demand for physicians works simply around the demand for medical care. Furthermore, there are many factors that affect demand. Price being one, availability of substitutes or income, and the preferences and tastes. The nature of the medical market revolves around the idea that there is imperfect information, which to some extent disassociates price with quality. Consumers have insufficient knowledge regarding diagnosis, treatment, and quality of care. This is why we rely on physicians to act in their best interest for each of their patients. The interaction between supply and demand results in market equilibrium. This price will not change unless there is a change in either supply or demand. Factors that affect supply include price, input prices, technology, and the number of suppliers. Price elasticity of demand measures the sensitivity to price. For an insurer, the price elasticity of demand depends on the number of close substitutes there are. The closer the substitute, the greater the price elasticity of demand. A relationship between an employer and an insurer can demonstrate this idea very simply. If an insurer marks up a price of his insurance, the employer may try to find a better substitute or decide to self-insure. The individual market for insurance is more price elastic or sensitive than the overall market for insurance. This is due in part to the availability of close substitutes. Cost shifting is the practice of raising prices to privately insured patients because public insurance or the uninsured do not pay their services in full. As we see in this study, this is evident in most of the mental health illnesses. In 2002, price-to-cost ratios of Medicare, 0.95, Medicaid, 0.92, and private payers, 1.22, are considered to be evidence of cost shifting. Cost shifting can be seen as price discrimination. This depends on the elasticity of demand. Less elastic means that the patient will pay higher prices than those with more elastic demand. When I think of this statement, I picture someone who has less worries about their money being more willing to pay higher prices than someone who is more price conscious and less willing to pay high prices. In conclusion, I would argue that there is a need for a more thorough assessment of the impacts of specific plans to accessing medical care and costs associated with them. A key limitation of this study is that although the authors were able to condense the types of insurance into 3 broad categories, meaning public, private, and uninsured, there wasn't any specific evidence on the types of benefits that these insurance types received, or whether the mental health services were included. Oftentimes, mental health is considered a non-covered service by insurance companies. The uninsured and underinsured people with serious mental health conditions seem to be reporting that their access and care is burdened by cost. This is a major debate in our healthcare economy to this date and needs to be further analyzed.